Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Joining us today for the first part of our mini-series on infectious disease diagnostics is Dr. Rohde, Regents Professor and Associate Director of the Translational Health Research Center at Texas State University, where he also serves as chair of the Medical Laboratory Science Program in the College of Health Professions. The good doctor has an extensive background in public health, having spent a decade as a microbiologist, a molecular epidemiologist with the Texas Department of State Health Services. His research focuses on antimicrobial resistance, which is something that fascinates me, with a focus on methicillin-resistant Staphylococcus aureus, healthcare-associated infections, and emerging zoonotic diseases such as rabies and hantavirus, and as we all know, probably represents an existential threat to humanity. He's a prolific author and sought-after speaker. He's published extensively and delivered over 100 keynote presentations worldwide. And in his free time, astonishing to think that he even has any, he loves to travel the world with his wife and taking care of his schnauzer, Timmy, presumably not quite at the same time. So welcome to the EMJ podcast, Professor Rohde. Lovely to have you here.
Thank you so much, Jonathan. It is a fantastic and humbling experience to join you today, and I look forward to our conversation.
Well, I am too. And boy, there's many things to discuss. But I think I always like to try and get, I guess, an oversight, a perspective. During your career, we've seen major advancements in diagnostic technologies. And I'm thinking back, both of us have got some very distinguished eminence grise atop our heads. I know in my career, microbiology has changed dramatically from what I learned in med school. But your perspective, breakthroughs in molecular diagnostics, what's excited you in your career and what has you, buzzing with excitement for the future?
Yeah, thank you for the question. And I really do appreciate the question because I often tell my students I've been teaching and working in both public health and in the medical laboratory, as you say, for about 3 decades, a little more than 3 decades. And I always tell my students when I first began my career in the public health lab in Austin, Texas, I actually helped develop the first rabies molecular PCR test to both identify and track the different variants. At the time, and I'm sure you can appreciate this, it was pretty manual. We did things totally different than what we see today. So, what's great about my career, Jonathan, is that in many aspects of my career, I was on the front end of kind of doing things by hand and really learning how to troubleshoot. And so, what I really appreciate fast forward 3 decades later is how automated, how sensitive, how multiplexed, all sorts of features that we have available. Probably one of the most fascinating things I've seen in the last few years is the use of widespread CRISPR based technologies. So, utilizing that during the pandemic, but also in many other areas, as we see now with diverse diseases, other emerging areas, even the idea of point of care testing at the bedside now that we see molecular diagnostics use. We just didn't do that, 3 and 4 decades ago. So to have that kind of effort, next generation sequencing, multiplexed assays that let us do panels for viral respiratory diseases, for example. And, in the current state of the world, pre and post kind of COVID pandemic, it's only going to increase our reliance on these tools, both in the human world, Jonathan, but also in the animal diagnostic world. And my career's kind of, I've had a foot on both sides of that. And I work in a One Health framework. So I'm always thinking about the animal, the environment, and the human because they're super interconnected and interrelated with respect to health.
And we've certainly seen that, haven't we, with, you know, uh, obviously with the COVID-19, but the so-called bird flu, the avian flus and the swine flus.
So many new vector-borne diseases too, like dengue and Zika, just in the last decade. Just and it's one of the things I'm actually keeping my eye on is vector-based disease because just so many vectors out there in the wild and elsewhere that are spreading infections.
Rodney, many years ago, I did a mini sabbatical with the Royal Flying Doctor Service, combining a love of aviation and medicine in a place called Cairns in far north Queensland. And so I was there many years ago, and I went back there a few years ago when a dear friend moved there, and we were sitting by the harbor. There was no harbor when I was there. First of all, it was a little fishing port, and we were having an adult beverage as the sun was going down, and suddenly the sky was full of flying creatures. There were bats and flying foxes and Lord knows what else. And I said, you know what? We didn't see those when I was first here. And he pointed at the hillsides, which when I was there first were rainforest. Now it was houses. We displaced all these animals and they were flying around and quite frankly defecating where we were having our drinks. And I'm thinking, holy cow, this is this is a problem, isn't it?
It really is. I mean, when you think of anything in the realm of zoonotic disease, that interface of humans and animals and insects and the environment, it really has changed dramatically, and for all the reasons you mentioned. And most people know this, but it's real world right now where people are kind of encroaching into those areas that we used to not really spend much time in. And in many of the things, we do as humans that do help us, for instance, creating waterways, building dams, clearing forest. And we might look at that as progress, but I think we all still need to continue to think about the impact of what that does on the animal, the insect, even plant species that, we are now basically in communion with in many ways. So, that opportunity, Jonathan, the opportunity for a jump of some pathogen from a insect, from another animal, from different practices in those areas are going to be a really important thing for us to continue to watch as we move forward.
I would like to think that we as a profession can depoliticize these conversations
Amen.
and educate the world because, unfortunately, they are politicized. And should I say, in some nations more than others.
Amen. And it really is, as you mentioned in the introduction, probably the last decade of my career, it's really become a an obsessive passion of mine is accurate science communication and health literacy, to the point where it's almost become, the first thing I think about now when and again, when I'm doing these opportunities, I absolutely love this opportunity because, as you know, digital media, podcast, social media, they're here and they're not going anywhere. So even though there's some negative echo chamber things that go on in that realm, there is the potential for really powerful messaging, and it's just going to be, I think, a battle, as we go forward to try to get that communication and push it down back into the schools, into the grade levels where, children that are growing up and others that are coming up through that will start appreciating expertise and science and how critically important it is to all humans around the world. We're so interconnected, people don't really realize that sometimes.
What do they say? Someone sneezes in Wuhan, someone.
Yeah, that butterfly effect is real for
Yeah,
sure.
exactly. So your research, as I mentioned, you focused on antimicrobial resistance, healthcare associated infections. Tell us about diagnostic tools evolving to help detect and combat superbugs like MRSA. And are we in the medical profession doing enough to raise awareness with our colleagues, patients, the media, and other stakeholders? And I believe that the majority of antibiotic use is not among human beings, but it's livestock. So, can you address the whole MRSA education?
Yeah, let me try to put all that in one answer for you. It's a big complex answer. Certainly livestock, the use of antibiotics and other types of medicinal agents in animal populations is well known. And I would agree that that's probably a large consumer. And when you look globally, of course, and this is maybe a different topic, but there's different regulatory issues. Sometimes it's easily used without a lot of regulation. That's a big problem we need to keep an eyeball on. And so, yes, livestock, human use, even in the environment when it runs off from animal farms into rivers and lakes, you even impact other forms of life. So it's a global complex issue that's difficult to handle. Part of it is creating new tools that you mentioned, new diagnostic tools, new pipelines for antibiotics and other agents that we can continually safeguard and only use when necessary against some of these so-called multiple drug resistant organisms. MRSA for me, when I became a professor back in 2002, I left the public health laboratory, and I really needed to move into a world where I could work on something that was more academic related. So rabies was kind of my background in zoonotic disease. It was hard to bring that into the university world because of the level of safety. You had to have a level 3, level 4 lab, and I just didn't have that at the time. So I moved into antimicrobial resistance, and MRSA was something I was interested in because my father, unfortunately, has dealt with this. He's in his 80s now, and he still sporadically deals with it. So I moved into that realm. And back then, the key technology was still kind of traditional microbiological identification, some manual, some semi automated, some automated. And then the all important, as I always tell people, the antibiotic susceptibility test so that you know which drug to use effectively. And you're not just using a broad spectrum shotgun, but you're using a rifle to try to get that thing taken out. But in that span of just 2 decades now, we're looking at MALDI-TOF technology. We're looking at some of the technology that allows us to multiplex around only AMR pathogens. We're looking at all of the molecular tools we mentioned earlier, like next gen sequencing and digital PCR, and ways to pinpoint resistance genes that can be transferred, as you know, from bacterial species to bacterial species. So we've just come such a long way, but there's still so much work to do. And part of it is just this ongoing education and getting people to understand that antibiotics are not a pill or a shot is not always the perfect first thing for a physician to prescribe. They really need to understand what the bug is. And we'll talk about this more, I'm sure, as we go along. Got to know the correct identification with all the different nuances of genetic variants now so that we can pick the right bullet, the right antibiotic that will really take out that organism. And then there's a whole nother world, Jonathan, that I really may not have shared with you too much when we met, and that is the really critical importance on the front end, which is the environmental spaces in hospitals and dialysis clinics, and how we watch infection prevention and segregating patient populations. And because when we give those bugs the opportunities to commingle, it creates transfer of resistance elements and things like that. So again, it's really complex. It's really difficult, but trying to hit it from all angles is going to be really important as we go forward. Most of the experts say AMR, antimicrobial resistance, by 2050, if we don't get a handle on this, by 2050, it will probably replace cancer as the number one killer in the world. I mean, hundreds of, just millions and trillions of dollars being wasted, and many, many deaths that hopefully can be avoided. So we've got our work cut out for us as we move along.
Absolutely. And the problem with these sort of distant existential threats is people see them as, oh, that's not my problem.
They really do.
And, I live in London, back in my native London, and I often walk past St Mary's, where there is a blue plaque on the wall, where I think it's on the second floor, where Fleming had his lab. And I think, what must it have been like, whether Fleming did or did not first isolate
Right.
penicillin? I believe there's a school of thought that he did not. But
What it must have felt like.
what it must have felt like to know that and I think of all the other advances that we've seen in medicine in our professional lifetimes, monoclonal antibodies, all these, immunotherapies, amazing advances in imaging, in Lord knows what. There hasn't been a paradigm shift in the treatment of infectious disease. So, what about the potential for bacteriophages or other thinking, other ways to supplement or supplant our current armamentarium of antibiotics that will address the whole issue of AMR, and the bacteria will go, damn, they've dreamed something else up?
Yes, yeah, I love that question because in the bacteriophage, is an interesting, and it's been around a while, right? I think historically people have looked at that. It makes sense. So for the audience, a bacteriophage is a virus that infects and usually kills bacterial species. So what a wonderful tool to take one microorganism and target another, more of a kind of a almost an organic biological therapy instead of taking a drug that might create resistance. So I am absolutely intrigued. I've been following some of the more current phage therapy. I actually had a graduate student about, oh goodness, about 10 years ago do some of her thesis work around a combination of phage and antivirals against a particular type of virus infection. So I think we're coming a long way there. I'm not an expert in phage therapy, but I think we have to explore the toolbox, um, because, as you mentioned, it's become so difficult to sometimes change people's mindset. I mean, we all know this. Most people walk into a primary care physician's office, your family doctor. The first thing they want is a pill. That hasn't changed in my lifetime. I'm 57 and I still see it happening where somebody wants an easy fix. Whereas if we can think about phage therapy, the other thing I would mention here, I think that's really important, I kind of brought up earlier, is the environment and how we can prevent. Can we prevent infections before they ever start? The famous quote, an ounce of prevention is worth a pound of cure, right? So if we can prevent these infections through better cleaning, better disinfecting, even how we build healthcare systems, we know that surfaces, medical tools, medical devices will be colonized, and bacteria will create biofilm, and they will be inherent in those spaces. If we can think about building materials and how we approach hospitals and healthcare facilities and how we clean them, because as I often tell my audiences, clean does not necessarily mean microbially clean. And it's really easy to look into a place and think that it's sterile, but it's, as you know, it's not. I mean, there's just so much. It's a living environment, Jonathan. So I try not to scare people, but I also try to educate them about, just because something looks clean and smells clean does not mean that it's sterile for sure. And so we need to explore those options as well. How can we better prevent the infection?
In the UK, in the healthcare environment, um, I I was just having lunch with a dear friend from America, and I spent half my career over there. Doctors in America dress differently to doctors in Britain. Doctors here don't wear white coats, haven't done for
Right.
quite a while, and they don't wear ties. Ties are not allowed because you touch the patient and they dangle all over the patient. I mean,
Absolutely.
it's like,
Stethoscopes, ties,
yeah,
just about anything you
you're
can
right.
think of is a vector, a vehicle for a bacterium, a virus, a fungal agent to attach to and be transmitted. And all the data shows this. We know this. So even if you have a patient who has C. difficile, a really nasty diarrheal illness in that room, even if you do not kind of follow this in the literature, it kind of makes common sense that that room should be considered problematic when they leave that room. And so there's data that shows that the chances go way up if you're the next patient in that room. So, how we process that room, how we clean that room, making sure we have time to truly eradicate the spores and the other things that might be left behind. So again, that I think it's an issue of time, money, and how we kind of move this forward, because it's, as you know, time is money. And so even in healthcare around the world, sometimes we're so worried about cranking out that patient or moving that room to the next one, is that we have to slow down and think about how we can be very careful with respect to how we house patients in hospitals and
Mm.
healthcare clinics.
Sort of Semmelweis type thinking, puerperal fever and all that. So switching topics a bit, I know you've done a lot of work, as we mentioned initially, with zoonotic diseases like rabies and hantavirus. Talk to us about the risk that those bugs pose, issues diagnosing infections early, and how we can improve detection and containment. Again, speaking about prevention rather than.
Yeah, I could talk about this for hours. This was the love of my life for when I first graduated. I got a couple of degrees. My first one was in microbiology, and I got a master's degree in virology. And I went to work for the Department of Health in Austin, and I ended up working in virus isolation and later in rabies and arbovirus, which are mosquito-borne viral illnesses. And Jonathan, just out of the being at the right place at the right time, Texas was in the middle of two different rabies epizootics. So, an epizootic is an outbreak in animals. One was in the Texas coyote, which is down in South Texas towards the ocean, the Gulf, and the other was in West Texas, which was in a gray fox. And I really didn't, I knew what rabies was in school, but I really hadn't planned on working with it. But here I was in the middle of these two epizootics in Texas, undertook one of the most amazing, I think, public health projects in my lifetime, and that was to try to contain and eliminate canine rabies in Texas. So I was on the inaugural team to create the diagnostic testing that I mentioned earlier, the PCR based testing to identify the specific variants, words we used in 2004 and back then and back in the mid 90s that we use every day now. You heard about that during COVID variant time, but we were talking about it way back in the 90s. And I not only got to do that, but I got to join the team. And here's what was phenomenal. We interacted with the Canadian Ministry of Natural Resources, the CDC, the Texas National Guard, of course, the health department that I worked for, and we delivered rabies recombinant vaccine to wildlife using fixed wing aircraft. And we basically obliterated South Texas and West Texas with these baits. We just drop them. We went from dawn to dark for about 3 weeks. We flew around, it's basically flying around the world 2 or 3 times because we just flew these lines. So this was also in the early days of GIS, GPS technology. And after about 10 years, we eliminated canine rabies, and it's not been reintroduced into Texas. So my hope was that we'd always take that technology to countries like Mexico and Latin America and other places where there's still 50 to 60,000 deaths a year from rabies, from simply because a lot of places don't take dog and cat vaccination seriously. And so if you could find a way to vaccinate wildlife and feral animals, it'd be really fantastic. But that was a life changing, transformative experience for me because it gave me the world view in my 20s of what global public health could look like. So that was fantastic. I also spent time in the laboratory and with the Zoonosis Control Division on their hantavirus rapid response teams. So again, kind of a one foot in the lab, Jonathan, one foot in the epidemiological world. It was just a fantastic time because I would go out and help these wildlife biologists and veterinarians. A lot of veterinarians were my bosses. So I really respect animal health and animal diagnostics. And we would trap and collect rodents. We would do animal and field dissection in the field. And then I would bring that back and do all of the antigenic and molecular characterization to understand hantavirus and plague and um, a number of mosquito-borne viruses like St. Louis encephalitis and on and on and on. So wonderful training. I always promote public health laboratories as a great training ground because that really transitioned well when I started working in healthcare and educating future medical laboratory scientists here in the Texas area as well as nationally. So kind of a big answer, but I can't speak enough about how fun that was and critically important to my future. And just to kind of wrap it up, it's just continued to explode. So every time we look, whether it's a flu issue, whether it's a SARS-CoV-2 issue, whether it's any name your bug right now, it seems to be dominated by zoonotic animal to humankind transmission. And so we need to understand those dynamics and we need to pay really critical attention to that and how we support surveillance, how we support the workers, not just healthcare workers, but public health, laboratory, epidemiologists. And, this is a struggle right now in the United States, and it's something I'm watching very closely. We cannot let that slip globally. That's a whole nother conversation, I know, but it's something I'm watching really carefully. Most of my colleagues are very concerned about this because you can't just bury your head in the sand and you'll lose ground, right? I mean, it's as we've talked about, it's a constant war, and if we are not careful, we'll lose ground, and we'll have to regain that if possible down the road. But it's something I'm passionate about, and I hope we can keep moving forward on fighting those types of topics.
It was fascinating hearing about using aircraft to bait in areas. As I mentioned, I'm a keen pilot, and I love hearing stories about.
Oh man, I we could do another talk about that. I've done it many times. It truly is, and it still is. It's still ongoing. So they still do it to kind of create a living immune barrier in the wildlife because we're always worried about rabies coming up out of Mexico. I mean, if you know Texas, there's this river called the Rio Grande, and there's nothing grande about this river. It's like a creek, and so animals can get back and forth pretty easily. So we're always
Without the
trying to.
passport, and
Yes.
I remember.
Yes, yeah, and they're using it now in the Southeast. There's a huge raccoon rabies, um, epizootic along the East Coast in the US. They use it in Canada, for the Arctic fox, so it's a tool that works really well. It's just a matter of getting, the funding and the adoption for it to be used in Latin America and other places where it could really save lives.
You know, I don't know if it's. I'm sure it must be available in America. There's a British TV personality, Jeremy Clarkson, who did a show called Top Gear for many years, and he bought a farm in the English countryside, and it's his journey about becoming a farmer. And I think most people like me who watched it really had an immense respect for how difficult farming is. And
Oh,
in one episode, he is dealing with, we have these wonderful creatures called badgers here. They're beautiful
yes.
animals, but they carry bovine tuberculosis
Yes.
and they're a protected creature. So the things that you have to do to, to manage it without,
Right.
and dealing with these limitations. And it's fascinating challenges. And as
It
you
really is, and it's interesting you mentioned that because, I'm a city boy now, but I grew up on a farm. My parents were they weren't really farmers. My dad was a railroad engineer, my mom was a stay-at-home mom, but he loved to farm, and so we had about 20 acres, and I grew up that way, raising cattle and pigs and, building fence. I always tell students, I had a lot of hard jobs growing up, so I appreciate people who do these types of jobs, but farming is a so important to the world, from both a production standpoint for meats and foods and grains and vegetables and things like that. But it's also, fighting the different types of disease. I can still remember my father working with, the local veterinarian to think about vaccinating his cattle and livestock. So some of the things we take for granted in the States and other developed countries where you can vaccinate your livestock or your domestic animals, that's not true, in all places in the world. And so that's education, and that's trying to get people to understand if you work on those animal populations, you help, raise the health of human population
Well,
as
we're
well.
going to come on to the vaccination issue in a moment, and it's an interesting one. But I remember at medical school learning about scrapie,
Yep.
um,
Prion based disease.
prions in sheep, and of course lived through the bovine spongiform encephalitis outbreak. And we've had mass. I know in America they've recently had an outbreak of avian flu and have had to slaughter a lot, which has impacted the supply of eggs and
Right.
become a major national issue.
It's
So
crazy. Yeah.
let's talk. We'll come on to the vaccine thing in a second. During the COVID-19 pandemic and the recent so-called mpox, the monkeypox outbreak, you became one of the most quoted experts on these topics. Based on your experience, what were the biggest successes and failures in infectious testing disease in testing for infectious disease during these crises? And to quote a Texas expression, I believe that one of my Texan friends taught me, don't go poking a skunk, John. I am a very few miles away from one Andrew Wakefield, one of the Britain's less proud moments, brought the term or inspired the term vaccine hesitancy. What of vaccine hesitancy and how do we combat this?
Yeah. What a big question. What a very big question. Let me kind of talk about COVID first. I've actually written some book chapters, and as you mentioned, I've done a ton of work here in the realm of science communication around that. Again, I'm very thankful and humble for my university, Texas State University. They reached out to me during that time as a credentialed specialist in virology. In fact, the only one on our campus I was reached out to kind of help not only here on campus think about safety. It's almost hard to remember the craziness of that time, which was 5 years ago, but just so much work. It was the most, at times frustrating, um, tiring, but also one of the most exciting times of my career, in all honesty, because I was able to put to work a lot of what I'd done for 20 years with respect to knowledge and stuff. So I do want to thank my university for that opportunity to be that spokesperson and that expert for them. It really was an amazing time. Probably the one thing I talk about the most with respect to what I think went wrong. So I'm going to start there. And this is just my own professional opinion, right? There's a lot of opinions here, but I've been at the CDC. I've worked in public health. I did it for 10 years on the ground, and then I still collaborate quite a bit with different colleagues in those areas. The Centers for Disease Control, Jonathan, was never meant to be a large scale, high throughput diagnostic testing laboratory. They are all about dealing with finding out difficult cases, what's happening, becoming kind of the spokesperson and becoming the place for most things to be ultimately discovered with really difficult cases, whether it's a new virus, whether it's something to do with water, whatever the situation is. And so when we started expecting the CDC to crank out hundreds and hundreds of thousands of COVID tests without really understanding their role, I think that was the first mistake. And I think you saw one of the successes because of that is we learned with some difficult learning, like it took a little time, which is part of the frustration. Finally, we went to corporate labs like Quest and LabCorp, and we said, "Hey, we need some help." And these places are full of amazing experts and researchers that really help develop some of those first assays and help things get kind of cranked up, and then the whole supply chain issues and distribution of things. One of the things I didn't learn until COVID, which now all of our hospitals change, so this is moving to healthcare, not public health, is hospitals, if you can believe this, it seems silly now to say, but it's just the way it was. They would sign contracts with industry for diagnostic tools and reagents, and they were like exclusive. And once that supply chain hit, they were kind of, for lack of a better word, screwed.
Yep.
I mean, they had nothing. And so that went away. Now they've learned that we better have multiple contracts across maybe globally, regionally different places so that if this part of the world is having an issue, then we can get it from that part of the world. Seems really simple, but nobody really thought about it. We were just, kind of signing these contracts, moving. So the supply chain issue, the part about not really understanding how to get that timeliness and that testing out. A lot of us have been screaming this for 30 years. COVID just kind of brought the hammer. A lot of us have been talking about this. We knew we weren't going to be well prepared. Thank goodness, even though millions of people died, which is really sad. It could have been worse, right? If it would have been a virus that had a 30% mortality rate, good grief, it would have been horrible. Some of the things I think that were kind of exciting and powerful that came out of that time was the use of mRNA technology. I'm still a firm believer in it. I always tell people that are worried about it, your entire body is full of mRNA. It's not scary. It's been used for 20 years. These tools, I think, are going to allow us we've never been able to keep up with viral evolution. And I don't think we'll ever get ahead of it, but we're as close as we have ever been with respect to pivoting every time a virus changes or some agent changes because of mRNA technology, whether it's creating vaccines or monoclonal antibodies or other types of therapeutics that we can track. That surveillance piece is so critical now in diagnostics to know when that variant changes, and now we can pivot to a new vaccine. So I think those are really important. No, you had another bigger question that was surrounding that. If you could remind me of that
Well,
last piece.
absolutely. And I'll tell you, it's a huge question. And, there are people I know who I otherwise consider to be very smart people. They have succumbed to the internet echo chamber. They are very happy to take their cat or their dog to be vaccinated, but they have very firmly, they joke about surgeons that we have very strong opinions, right? And we're occasionally right. People have very strong opinions with no basis in fact, and unfortunately, their opinions are very, very dangerous. I mean, we're seeing at the moment in the United States outbreaks of measles.
Right here in
Measles,
my home state.
yeah, I know. I know. I was looking at the numbers before this. Measles is, I believe, one of the most, if not the most, infectious disease, and it kills people.
It does.
It kills
And
people.
if it doesn't kill, the morbidity, there's some really bad side effects from the actual infection.
Colitis and such like. So
Right.
my my question to you is, prior to the Wakefield MMR nonsense, and let's be very clear, vaccines do not cause autism. Vaccines
They
do
do
not
not.
cause inflammatory bowel disease. How do we address this issue? Everyone wants to pussyfoot around. I've personally reached the point in my life where, I'd rather ask for forgiveness than permission. I think we have to start getting a little bit more vocal as scientists and say, okay, peeps, here's the fact. Here's the facts. So, Professor, give us the
Yeah. Oh man. Wow. What a mess. Right when this topic comes up. So I wished I had a time machine. First of all, that I could go back and grab Wakefield myself. I mean that single publication, which again, I don't even want to give it the airtime, but let's just state that it was completely a terrible research design. It was very few cases. All the data, all the research expertise has proven it invalid, and yet the horse is out of the barn, right? And people have latched onto that. And so that is one issue that we have to be vocal. Experts, scientists matter. We have to speak up, as you just said, and we have to continue to do that. The other thing I think that's happening, I'm battling this in my own state, in my own country. I do it all the time. It's frustrating, but I keep doing it because there are people that just are in those echo chambers. And what I have to talk to people about, if they're younger than me, so I'm 57, when you start talking to my college students, 20, 22, 25, even those that get into 30s, they have never in their life dealt with measles. Guess why? Because vaccination eliminated it, right? We eliminated it in the United States in 2002,
2002.
right? And so it's basically was gone except for the occasional imported case. And here we are, Jonathan, in 2025, dealing with an old foe that we should not be dealing with. And sometimes people forget, because of the very success of these vaccination tools, that they are very blessed to live in these times. My grandmother, my parents, I'm sure you have people that talk about losing children to polio or measles, and so on and so forth, or some terrible, they have to live with the iron lung, for the rest of their life. People don't see that anymore. And I don't know if they even believe it, which is crazy, or they think that the infection is the safe way to go. And as you know, and most experts know, that's a very dangerous attitude, a very dangerous dogma to kind of think that way. So I think we absolutely have to speak up. We have to be careful. That's why I'm here talking to you. One of the reasons I love doing podcasts and YouTube channels and things like that, and even writing important explainer articles, is the scientists out there, the physicians out there, the researchers that are really, really working in these areas, they have to learn to tell a story. They have to talk to people like I just mentioned about my grandparents. They have to talk about why it's so critical. You can't come at people. We saw this mistake during COVID, by the way. You can't come at people and hammer them with 18 research articles. The research is important, but you have to take that data and you have to get it out in a way that impacts people. And then, unfortunately, including right now here in Texas, I think, a child died just a week ago, the first measles death in 2 decades, and maybe longer. That's such a sad story, but we have to take that example and we have to use the power of how measles kills, how measles maims, and talk about that it's only one hiccup away. Most epidemiologists and experts say that if you don't have 95% of the population vaccinated, you are that close from outbreaks. And this is what's happened in Texas. We had a community of people who didn't believe in it, and that's where it started. And now you have, I think it's 159 cases as of yesterday, and it's just percolating. right? And so thankfully, the surrounding areas are pretty well vaccinated, and hopefully that will burn out, in that one spot. But it's a wake up call and a big one. We've had several. Pertussis is cooking around the world, including in the U.S. There's a lot of different diseases that we consider eradicated, or we don't have to worry about them anymore, and they are not going away. As you know, microbes will outlive us all. They are the most adaptable, crafty, diabolical thing on the earth, and I consistently tell people they don't give a damn what we think about our ethnicity, about our income, about where we live, whatever your excuse is, they don't care. And while we sit around and argue about this in the way of vaccine skepticism and things like that, they're like, thank you. We're going to rise up and take over. So I don't know if you have more comments on that, but it's something that I talk a lot about. I write a lot about, and sometimes I bang my head against the wall because I can't get to people. But we have to keep trying. We have to keep trying, and hopefully those people don't lose someone they love, because that is the ultimate lesson, is that you could be that person that denied it and denied it, and all of a sudden you've got a child. And oh, that's my biggest concern, is that infant, they don't have any voice. And so when parents stop vaccinating childhood preventable diseases like measles and polio and diphtheria and tetanus, I mean, I just shake my head. It just seems so tragic.
I think you nailed it. It's about communication, and it's yes, there are people talking, and I've done a few social media type things on this, and I will share with you that some of the responses have been not good. Uh, the
Absolutely.
people who have these beliefs, they've been endorsed, enhanced. I've had I've had very threatening communications
Me
telling
too.
me that, and also accusations of being in the pay of big pharma.
Right.
That's
Right.
that's the usual one.
That's the easy excuse answer, right? It comes, a lot of my colleagues, here in Texas, Dr. Peter Hotez, he's in Houston. He's an amazing scientist. He's created low cost COVID vaccines, and he is constantly attacked, including threats against his family and things like that. So, I think, we have to continue to speak up, and we have to try to talk to people in a way that they understand we're just trying to state the obvious, and we're following the science, and we're using the best case scenario. But what worries me during this time frame, and this has really been a decade or so where it's really bubbled to the surface, is I often tell people what I worry about is it's this almost global attitude around expertise, like physicians don't matter anymore, and PhD trained scientists don't know what they're talking about, or they're paid by pharma, or they have some agenda. Most of us entered public health or healthcare because we were passionate about helping people, and so that's another troubling piece, is how did we get here? How did we get here that people think that we don't?
Because we've allowed the other side to have a voice, and we have not stood up and said, hang on a second, this is not true, right? This is not true. And yeah, it needs people like you doing more podcasts, going on television, talking to these people calmly and quietly, and saying, do you vaccinate your dog against rabies? Yeah, you do. Why? Because you don't want your dog dying of rabies, right? Well, you're the same. So let
Right.
me ask you, going back to the pandemic thing, and you've talked about all the lessons we've learned. What one or two things do we need to do to be better prepared for the next pandemic when it comes, and it will come?
It will come. It will come. And our biggest worry, as you mentioned, is a new or an old foe like influenza that has a much higher mortality rate. And so that's what we're worrying about. So I think, this is my kind of my pat answer. It's probably not a popular one right now, but we must we must address public health and healthcare funding, the professionals that do that work, We have major, so this is something we haven't talked about. It's something true in my world of medical laboratory science. Laboratorians, nurses, physicians, all of us, major healthcare workforce shortages. We have to address the types of funding and the policy that we need going forward so that it's not a knee-jerk reaction, Jonathan. I've said this for some, again, 3 decades. I've lived through HIV. I've lived through, you know, the first SARS rounds and the different influenzas. Usually what happens in America and probably elsewhere is there's a knee jerk. We're going to throw a lot of money at HIV. That's great. We needed it. We threw a lot of money at SARS-CoV-2. We needed it. But what we need is a sustained effort where we treat public health and healthcare like we do our defense budgets. What 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 more dangerous and scary enemy than microbes?
And you made the point that the microbes cannot see national borders and international collaborations. And I'm not going to get into politics, but
No, but you're right. I mean, global interrelatedness and communication are paramount. We're all allies in the war on AMR or the war on new novel pathogens because they attack us all.
I was just in China for a meeting a few months ago about the use of a radioisotope for treating disseminated malignancy. And this hospital I visited has probably the largest experience in the world in using this particular isotope. And I spent time with this very dedicated, very good medical oncologist, radiation oncologist, who was doing this work and very keen to collaborate and share data to help the patients that she looks after with cancer. And you know, nowadays you have to be careful about having these conversations lest you be labeled. So, well, I agree with you. And when I come on to my last question, I think I know what you're going to wish for. Um, and it's basically this. I ask every guest if you had three wishes um, for your area of healthcare, what would the good Professor Rohde ask for?
Yeah, I appreciate the question. First of all, I want more wishes because
You
there's
get
so
three,
much.
don't be greedy.
Yes, I think, if and these aren't in any particular order, but one of the things I have dealt with for 30 plus years is I would wish for at least in the US and globally, really is more awareness and recognition around the professions I work in, whether it's public health or medical laboratory scientist. Um, a national license for all of medical laboratory scientists and public health, the types of things that would allow us to be understood as experts. That's one thing. We've kind of mentioned this earlier. I would love for us to continue to move forward in technology and diagnostics, real time tools. And we're getting closer, but what I really would love to see is, can we find a way in the laboratory to identify all types of microbes, I mean, as soon as possible in real time, even to the point of out in the field. So I've worked a little bit in this area around field diagnostics tools, so surveillance tools. And then the all important, can we then also almost immediately know which antibiotic, which antiviral, which antifungal is going to be really crucial to treating that? And then lastly, and this is probably where you knew what I was going to talk about. I just mentioned it. So this whole realm of public health, animal, human, environmental support, surveillance tools, the kind of support we need to be monitoring global disease and infections. As we mentioned, you can't be an isolationist in public health or infectious diseases because they just don't care. And so those are really my three big wishes, and so many more. But those three, I think, would help get us, closer. And then ultimately, I just hope we continue to globally collaborate. I know it's challenging right now, but independently, we can't survive. We have to be tied together to this public health issue around the world.
Yeah. Yeah, there's a friend of mine who's been a guest here, who's a five-time uh, astronaut on the space shuttle program, and he made a point that I think many of his colleagues have made that you can't see borders from space, and that a nuclear bomb goes off, or there's a nuclear accident, or in one place or an earthquake, everywhere is affected.
Everywhere is going to suffer,
And the
right?
sooner we can get to that place, the happier this world will be. I wish we could talk more, but what I'll say is we will talk more. I'd love to have you back and let's have a focused discussion about any of these topics because
Absolutely.
you're an utter delight to talk to and clearly very, very knowledgeable about your field. Professor Rodney Rohde, a joy having you on the program. Thank you,
Thank you
sir.
so much. I really appreciate the invitation and have a great, great week.
You too, sir. So, to the folks listening in, if you're not already subscribers, you can subscribe on all the usual platforms. And having subscribed, say something nice because that means that we can keep going. And check out the archives. There's hundreds of episodes with lots of very cool, interesting people. So, if you join me next week, please, that would be a delight on the EMJ podcast. Until then, I'm Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, and stay curious. Bye for now.